Hello and welcome to my audio medical basics, where I read medical books to your ears when your hands are too busy to hold a book. If you like, please don't forget to like, share, and subscribe. Let's continue reading from my case files book collection. And today we will read from this book here, the case files book about Obstetrics and Gynecology. As mentioned earlier, I'll be reading one case from this book and move to another book next time, as we will decide later, inshallah, will it be a cycle or should we change this. So let's go. Today we have in the Obstetric and Gynecology book, we have a case of urinary incontinence. So a 48 years old multiparous woman complains of urinary incontinence, which is related to stress activities. There is no urge component and no delay from the valsalva maneuver to the loss of urine. So the most likely diagnosis in this patient, genuine stress incontinence. Genuine stress incontinence. The question was, what are the most likely physical examination findings in this patient? It was a question in the case. So the most likely findings are hypermobile urethra, cystocele, or loss of urethrovesical angle. And what is the best initial treatment in this patient? Kegel exercises and timed voiding. So the objectives in this case is to discern or differentiate between the typical history of genuine stress urinary incontinence versus urge urinary incontinence. So we have genuine stress urinary incontinence, GSUI, and urge urinary incontinence, UUI. To know that the cystometric examination can be used to distinguish between the two etiologies and to know the treatments for both entities mentioned earlier. Considerations. The patient's history is very typical for genuine stress incontinence. She has loss of urine concurrent with coughing, sneezing, or lifting. There is no urge component or a delay from cough, as these findings would be consistent with urge incontinence. So there is no urge component or a delay from cough, as these would be consistent with urge incontinence. There is no evidence of diabetes or neuropathy, making overflow incontinence unlikely in this patient. The pelvic examination likely reveals a cystocele, which is bladder bulging into the anterior vagina. So the pelvic examination likely reveals a cystocele or a loss of normal bladder urethral angle, which is a hypermobile urethra. Both of these findings, the cystocele and the loss of normal bladder urethral angle, both of these findings of pelvic relaxation may be associated with the anatomic problem of genuine stress urinary incontinence, the bladder neck being below the abdominal cavity. In patients with urge incontinence or mixed symptoms, such as loss of urine with valsalva and urge to void, in these patients with urge incontinence or mixed symptoms, cystometric examination can be helpful to differentiate between genuine stress and urge incontinence. An accurate diagnosis is important since the therapies for these two conditions are very different, and surgical therapy may actually worsen urge incontinence. With genuine stress urinary incontinence, initial treatment usually entails pelvic floor strengthening exercises called Kegel exercises. If this is unsuccessful, then options for treatment include urethropexy or transvaginal fixation. Urethropexy is surgical fixation of the proximal urethra above the pelvic diaphragm, suburethral sling, or transobturator. Definitions. Urinary incontinence is the involuntary loss of urine that is objectively demonstrated and creates social or hygiene concern. Genuine stress incontinence is incontinence through the urethra due to sudden increases in intra-abdominal pressure in the absence of bladder muscle spasm. Urge incontinence is loss of urine due to an uninhibited and sudden bladder detrusor muscle contraction. Overflow incontinence is loss of urine associated with an over-distended hypotonic bladder in the absence of detrusor contractions. This is often associated with diabetes mellitus, spinal cord injuries, or lower motor neuropathies. It may also be caused by urethral edema after pelvic surgery. Cystometric evaluation is the investigation of pressure and volume changes in the bladder with the filling of known volumes. It's often used to differentiate between genuine stress urinary incontinence and urge urinary incontinence. Mid-urethral sling procedures. This is supporting the mid-urethra with a hammock-like effect with procedures such as tensionless transvaginal tape, TVT, or transobturator tape, TOT. Transvaginal tape procedure is a minimally invasive procedure used to fix the proximal urethra retropubic via a blind technique using a special hook-like instrument to place a synthetic tape under the urethra. That was the transvaginal tape procedure. Transobturator tape procedure, a minimally invasive procedure similar to the TVT but originating laterally to try to avoid the bladder or bowel injuries that have been reported with the TVT procedures. TVT is short for tensionless transvaginal tape. Okay. Clinical approach. Okay, they will keep the clinical approach for part 2. Thank you for listening to part 1. So see you all in part 2 of this urinary incontinence case.